Good afternoon, everyone. This is Heather, social worker from the Alzheimer's Foundation of America, and I'm happy to present today's special edition Care Connection live webinar. Today we have a special guest speaker. Her name is Dr. Chia Ying Chow, and she's a licensed psychologist in California. She is a UCSF trained specialist in treating hoarding. She has worked with over 100 individuals with hoarding disorder, applying cognitive behavioral therapy, and is currently developing a compassion focused therapy treatment protocol for hoarding. Today, her topic is hoarding disorder in the older adult population and ways to help. Dr. Chow, please begin the presentation. Thank you.
Thank you. I would like to give big thank you to Heather for her organizing and inviting me to participate in such a very meaningful and very important cause. So today, let me see if I can get the slide to move. Okay, so today I would like to share my understanding and some experiences working with individuals with hoarding disorder. And before I begin, I just really want to say welcome everyone, and I'm very glad that you are interested in this topic because hoarding is a long existing phenomena, but it's such a newly identified psychiatric disorder. So there are still many things that people have some misunderstanding about it and some curiosity about it. So I'm really glad this interests you and you are here with us today. So, sorry. Okay. So this is the outline of what we are going to cover today. So first of all, I'm going to give the introduction of what is hoarding disorder based on the DSM-5 criteria. And then I'm going to talk a little bit about what is it like and how is it affecting the elderly population. And then the next thing, we are going to understand what we know currently about the contributors to hoarding. And finally, the most importantly is how can we help? All right, so this is the criteria for diagnosing hoarding disorder that's currently in the DSM-5 system. And so hoarding is a newly identified disorder, as I just said, and it's only included in the latest DSM-5 system. So it was recognized as a disorder in 2013. So the first criteria that we see here is the individual has to present persistent difficulty discarding or parting with possessions, regardless of their actual value. And then the second thing is, so the difficulty is due to the perceived need to save the items and the distress associated with discarding them. So this is a very important distinction. So, for example, if somebody has difficulties discarding with things because of more purely because of their cognitive functioning. For example, for people with Alzheimer's disease, they may not have the best executive function, so they are simply having troubles categorize things and making decisions, as opposed to more like psychological attachment or perceived fear of making the wrong decisions. Or the very negative consequences about what if I make the wrong decision. So the second, the criterion B here is more about, to diagnose people with hoarding disorder, it has to be something more along this line. It's more to do with the psychological attachment to things as opposed to executive function deficit. So then the third criterion here is the difficulty discarding possessions results in the accumulation of possessions that congest and clutter active living areas and substantially compromise their intended use. So as you can kind of tell here, the criterion C is almost like how severe does the situation needs to be in order for us to diagnose someone with a mental health disorder here. So if the situation is not severe enough, meaning it's not causing them not being able to use their living space easily, then it's kind of like we will have to observe whether this person meets the criteria for the diagnosis. And similarly, for the last criterion, such difficulty causes clinically significant distress or impairment in social, occupational, or other important areas of their lives. So this is the criteria for diagnosing hoarding. And so hoarding disorder is very, very common, or it's more common than we would imagine. So as far as the research has discovered now to date, we know the prevalence rate in the US and in Europe is about 2 to 5%. And as you can see in the chart, in the figure here, so this the line at the bottom here is the each age group, and you can see that the prevalence rate when before people hit their mid-age is about 2, 3. However, as people get older, the prevalence rate of hoarding becomes so much more prevalent among people who are 65 years old or older, or those who are approaching 70. The prevalence rate of hoarding disorder is almost 6%. So that if I do my math right, so that means if you line up 12 people or 13 people who are 75, who are 70 years old or older, one of them has hoarding disorder. So the cost of this issue is not only in the individual level, but it's also in the societal level. So hoarding disorder directly contributes to up to 24% of death by house fire. And as an example, in San Francisco alone, over 6 million per year is spent by service agencies on hoarding related issues. And so then, of course, you can also imagine in the individual level, 8 to 12% experience actual or threat of eviction. And this is the data that we collected in UCSF in a very big clinical trial. So in our data, the people who participated in our study, more than half of them have severe difficulty moving freely in their home and difficulty eating at their table, and have a lot proportion of them have difficulty preparing food or exit the house quickly. And so if you can imagine, these are elderly people, and so having these issues is very, very significant problem here. So next, now we move to the third agenda item for today. So this is one of our main focus of today's topic. So we are going to look at a few contributors to hoarding disorder. So the first thing that I would like to introduce to you today is about the genetic factors. So far, the research has found that genetic factor account for 32 to 55% of the phenotypes of this hoarding behaviors. So although we don't know currently specific genes related to it, but we can know that genetic factors play a very important role in this population. And there's some relevant clinical observations and some scientific findings here that supports this genetic findings. So we know that hoarding can start in childhood. So among half of the individuals who currently meet the diagnostic criteria for hoarding disorder, half of them will report that they can recall the start of their hoarding behaviors even under age 10 or under age 18. So you can see the chart here on the right hand side of the slide. So I don't know if you can see my mouse moving, but I'm just gonna assume that you cannot. So if you see the bottom of the figure here, so the bottom is the age groups, and as you can see, the first and the second bars, the first bar is under age 12 and the second bar is between age 12 and 18. So these two bars contribute to about half of the people who have hoarding disorder. So that means that about half of these individuals that they started to show hoarding behavior since they were a child. And of course, at this age, it's really hard to diagnose someone with hoarding disorder because most of these kids they will live in with their parents, and so a lot of the things in the house, a lot of the things they collect may not be all freely controlled by themselves. There will be some intervention by their parents. But it's also very common that these kids, they also live with parents or relatives that themselves have hoarding behaviors. And actually, clinically, we see a lot of individuals, and when we interview them, they can identify some relatives. It may not be directly their parents, but they can remember their grandparents or their uncles, some relatives having this challenge, and so that again kind of support the genetic findings. All right, the second big category of contributors to hoarding is the cognitive dysfunctions. So although these are not the causes for hoarding disorder, but we do see that these cognitive dysfunctions play a very significant roles in how they affect hoarding disorders development and maintenance. So the first type of cognitive dysfunction is executive functioning. So these include difficulties in forming effective strategies. So as you can imagine, if you have a lot of stuff and you need to make decisions about what to keep, what not to keep, there are some strategies or many strategies that you would need to have. For example, you need strategies to categorize things. And for example, like if you imagine you're sorting paper, you need to categorize different types of papers. And then you need to come up with some criteria about if it's, say, older than 5 years old, then you could discard them. And so some of these functions are kind of not not functioning as well in this population. And the other example includes impulsivity and mental control. So a lot of times we make decisions, and we are able to more logically make these decisions. But it's been found that in this population, sometimes because they are very afraid of making the mistakes, so sometimes these individuals, they may function in a better safe than sorry kind of frame of mind. And then the next category is working memories and ADHD-like symptoms. So, for example, these for these individuals, it's really hard for them to hold all the information in their mind, and to remember what they were starting to do. So sometimes they can come to their kitchen and thinking about sorting certain things in the kitchen, and then as soon as they get there, they forgot why they get there. And it's very it's a very common issue in the elderly population. And so, like I said, these are not the pure causes for hoarding, but we do see that these things make it even harder for these people with hoarding disorder to tackle the problem areas. And the other very newly identified issue is the visual information processing. The research has found that individuals who have hoarding disorder, it seems that their ways or their styles of looking at things may be a little bit different from people who do not have this challenge. So, for example, it's very common for these individuals to have a very good eye about details. So they see a lot of details in things as opposed to the bigger picture. So that is a gift, but at the same time, it's a burden. The reason why I said it's a gift is because they are able to appreciate the beauty that most people do not. So they can see all the different grades of pink, for example, and different details in the texture of something, and that most people do not. So for them, it's really hard to let go of things sometimes for this reason, because they see so much beauty. And the other big categories that contribute or make hoarding more challenging for these individuals are some psychological mechanisms. So we've identified a few quote unquote pro-hoarding behaviors. So like I said, a lot of these individuals have at least perceived challenges in remembering things. So, I want to clarify that the research is still ongoing about whether these individuals have actual memory deficit, or it's a perceived memory deficit by them. So far, the evidence shows that these people with hoarding disorder don't actually have worse memories. However, they perceive their memories worse than people who do not have hoarding issues. So, so as you can imagine, if you believe that your memories are poor, and so you will probably naturally feel like you need to keep possessions in view. So a lot of these individuals feels like, oh, they have to put everything, lay the papers on the desk, so that they can see it. And so if they can see it, that's the only way they can remember it. But over time, more things got laid on the table and piled up. And so very related to this point is the low confidence in memory, and and also the perceived consequences of what if they forget. Something very negative in their perception is there about forgetting. And the other thing that is also very common that I see clinically is the sense of responsibility for their possessions and the environment. So a lot of the individuals with hoarding issues, they have very big heart. So they feel very responsible for possessions and for, so when they decide to give things away, they decide to discard things, they want to do it in the most environmentally friendly way possible. And they feel the huge responsibility to do it in the right way and send the things to a good home and make sure that the things will be appreciated and be used. And so this is a huge amount of burden on these people, but it also a lot of times makes me feel like um, my heart soften when I see how much they care and how much they are trying to do their best. And the other things that's also very common is the emotional attachment. So a lot of these the things that people with hoarding disorder keep are things from passed down from their parents or their deceased relatives or beloved ones. So all these items don't just mean items. These items means memories and the relationship for them. And the last thing here is the perfectionism and fear of making the wrong decisions about discarding them. And a few newer concepts, newer things that are starting to be found to be associated with hoarding includes the negative self-perceptions. So the newer research has been finding that the uncertainty about self-worth and shame and self-criticism are very, very significantly associated with the severity of hoarding symptoms, and also intolerance of uncomfortable emotions, distress, and uncertainty. And so, as you can imagine, that the intolerance of uncertainty, say uh, to holding on to hold on to things seems to provide a certain sense of safety because so that as long as I have all these things around me, then nothing can go wrong because I am not it's kind of like better safe than sorry, and it's really very closely related to the lack of capacity to tolerate uncertainty and uncomfortable challenges. Okay, so the last categories of factors that can contribute to hoarding is the environmental factors. So there are a few types of environmental factors that have been identified. The first type is the lack of familial warmth when the individuals were growing up, and general life stress, particularly interpersonal stress, and trauma. So in a study that my colleagues and I recently published, we were looking at the DSM-5 defined trauma. So we defined the DSM-5 defined trauma this way. So being exposed to or witnessing actual or threatened death, serious injury, or sexual violence. And in this study that we published early this year, we found that 95% of the individuals with hoarding disorder in our sample have experienced at least one type of trauma. And the average number of types of trauma is 7. So these are not incidents of trauma, it's 7 types of trauma. So that means some of the type can be repeated. Say, for example, childhood abuse. It's not, it's usually not just one time, it's repeated and chronic. So this is kind of something that I just repeating something that I just said. So there's no evidence so far to suggest if trauma is a cause of hoarding. However, a lot of these individuals have experienced trauma. And its trauma is associated with the onset of hoarding for those who started to show hoarding tendencies later in life. So remember the figure that we saw before. About half of these individuals can identify that they can remember that they started to have hoarding behaviors before they were in adult. And so that means around another half of them started to show this tendency later in their life. And usually these people are the people who are able to identify, oh, it was after that traumatic incident, for example, losing my husband, or for example, being the fire burned down my house, and then they started to show hoarding tendencies. So these findings suggest that trauma-informed or trauma-sensitive therapy for hoarding is really important. So before we look at how we can help, let me just very quickly summarize what we were looking at in terms of the contributors for hoarding. So the first category that we looked at are the genetics and the cognitive dysfunctions and the psychological mechanisms and the environmental factors. So I wanted to pause a little bit here to just to reiterate or to clarify one of my intentions of doing public talks like this is we have so much stigma for people with hoarding disorder, and there's a lot of misunderstanding about these people being lazy, filthy, and they just don't care. But it's wrong. This is a psychiatric disorder. It has nothing to do with being lazy at all. And so see, the science has already found out all these different things. So we wouldn't blame anyone for having PTSD. So why would we blame anyone for having hoarding disorder? So I just wanted to share that before we look at how we can help. Okay, so the current therapy, the current standard treatment for hoarding disorder is cognitive behavioral therapy. And so it can be facilitated by clinicians, and it can be done in individual therapy or in group therapy. And it can also be facilitated by peer facilitators. So there is a self-help book developed by Dr. Tolan, Frost, and Steketee. So the book is called Buried in Treasure. And so this book was in the beginning a self-help book, and so the authors of the book and and a very experienced peer facilitator, Lee Shore, they have started to use this book and to develop a peer facilitated groups. And so if you are interested in this Buried in Treasure group, it's a peer facilitated group, and I would encourage you to Google Buried in Treasure, and in your local area, chances are there are groups going on in your state or even in your city, and you can also contact the authors, and they can also point you to find resources to have you form your own Buried in Treasure groups in your area. And so how is CBT working in terms of the effectiveness in treating hoarding? So in the meta-analysis for the clinician facilitated CBT, so far the studies have shown that 35% of the individuals who received CBT can reach clinically significant symptom reduction. That is defined by a 14-point decrease on the saving inventory revised. And again, if you are interested in this inventory, you can also Google it, and it's free and it's online. And so I mentioned that there's the, you can do a CBT can be led and facilitated by clinicians, but there's also peer facilitated groups, the BIT groups. So we were doing a clinical trial at UCSF, comparing clinician-led CBT groups versus peer-led CBT groups. And we found that actually the clinician-led and the peer-led groups has no significant difference in terms of the effectiveness. And so overall, more than half of these people reached clinically significant symptom reduction in our study. So this is a very, very good news, because there aren't so many hoarding there aren't so many clinicians who are specialized in treating hoarding so far, because hoarding is still a very newly recognized disorder. So it's a very good news to us that the peer-facilitated CBT is working almost as effective as the clinician facilitated CBT, and so that gives us the confidence to broadly develop BIT groups in all over the country. And so if you are interested in this paper, you can Google Matthews 2018 Hoarding Cognitive Behavioral Therapy, and it's open access journal, and so you can download it online too. So in addition to cognitive behavioral therapy, is there anything else? And that was my question when I was one of the clinicians who were using CBT in the clinical trial at UCSF. So in my experience applying CBT, I was really impressed by how effective CBT is. However, I'm also seeing limitations of CBT, particularly in addressing procrastination and addressing emotional intolerance or intolerance of difficult emotions. So, and also a big topic that I feel like CBT can use some improvement is the more focus on addressing shame and self-criticism. And so because of this observation, I started to look into compassion-focused therapy. So there should be, okay. Yeah, so how does compassion-focused therapy work in terms of addressing hoarding? So this is one of the many different different techniques about CFT, compassion-focused therapy. So so in CFT we talked about the different motivational systems. So first, let's look at the threat system, the red circle here. So if you imagine that you are functioning in a kind of psychological state where you focus on looking out for danger, looking at how you can defend yourself, looking at how you can attack to protect yourself, then that means that you are in the threat system. So for the individuals with hoarding disorder, when they are functioning, when they are operating under this system, that means they are focusing on how to be safe, how to protect themselves. And at this kind of state, if you ask them to consider let go of certain item in their home. I think that's almost impossible because holding onto things is one of human way of protecting themselves, or one of the ways for humans to feel safe. And there's another system that CFT talks about is the drive system, is the yellow circle here. So this is the kind of internal state when your focus is on how do I win? How do I obtain more resources? How do I run to the front? And so if you imagine walking in the supermarket and you see a sale sign and your favorite cookies are on sale, and there were only 2 packages left. And if you're operating under the drive system, you will get as much as possible. So you run and then you grab everything, and this is very much resonating with the people that I work with hoarding disorder, especially when it comes to the acquiring challenges. So a lot of these people, they are really, really sensitive about bargains and really, really focusing on getting a good deal. So that is kind of like functioning under the drive system. And the compassion-focused therapy has a lot of techniques that focuses on the training this other system, the green circle here, the soothing system. This is the kind of state that we feel content and we feel safeness. So it's very different from safety. We are not, safety means that there's danger out there and I need to defend myself. But this is safeness. This is, imagine you were sitting down with your pet dog or your pet cat, or sitting down with your loved one. You feel content, and it's not conditional. You just feel content and you can let go of the cookies that you see in the supermarket. You don't have to get that in order to feel happy. You can just be happy even without the cookies, for example. And so this is the kind of like the one of the basic frameworks that CFT is based on. So we train the individuals to boost up their soothing system by developing compassion for themselves and for the people they encounter. And in the pilot study that we did at UCSF, we recruited individuals who went through cognitive behavioral therapy, however, were still symptomatic, to participate in compassion-focused therapy. And the finding was pretty positive. We found that after receiving compassion-focused therapy as a follow-up treatment, these individuals' average hoarding symptom severity dropped from 61 to 41. 41, which is the cutoff point for clinically significant versus not clinically significant hoarding symptom. And very similarly, we also found that the compassion-focused therapy significantly reduced shame, self-criticism, and ambivalence about self-worth, and a lot of avoidant coping mechanisms such as procrastination, and it also significantly improved distress tolerance. So because of this this rationale, and this is my personal passion, I've been developing a compassion-focused therapy protocol and continue to collect data in my private practice on this method. And so in terms of other methods that are also being developed, so one thing is cognitive rehabilitation and behavioral techniques. And these are methods that have been studied in UCSD by Dr. Ayers and her colleagues, and specifically addressing the executive function deficit these individuals have. And apart from that, in the field of psychopharmacology, there are studies going on to find out if there are effective pharmacological treatment or medicines to treat hoarding disorders. And so far, the findings are that some SSRIs are effective in treating the commonly co-occurring problems with hoarding, such as depression, such as anxiety. So these SSRIs are effective in treating these co-occurring conditions. However, there hasn't been studies shown that they are effective in directly addressing hoarding symptoms. So in addition to all these therapeutic or pharmacological ways that we could help with hoarding, I also would like to emphasize other ways that that many of us, regardless of whether you are a clinician or not, many of us we can know and we can help. So I think one thing that for people who are who have the influence to influence policy making is we really need to know that hoarding disorder is a chronic psychiatric disorder. And so to develop infrastructures for long-term care is very important. And that means affordable, accessible, and specialized treatment for hoarding. And number 6, the right understanding, reducing stigma, is also very, very important. And so this is the kind of report from our partner, the Mental Health Association in San Francisco. So this is a nonprofit organization that provides free resources, including treatments and including groups for people with hoarding disorder. So there are a lot of people based on the prevalence rate. There are about 40,000 people that may have hoarding disorder in the San Francisco Bay Area. However, only about 150 people per year seek help in this mental health association. And so we believe that stigma makes quote unquote coming out and seeking help really, really hard. So that is again why I really want I really want to reiterate my intention of doing the webinar today is to help provide right understanding about this mental health issue, and I really hope that all of you here can have this and help to spread the right understanding about this mental challenge, so that we can together work on the attacking the stigma for this mental health issue. And finally, I would like to stress that forced clean out is not the solution. So a lot of people who went through forced clean out, they can just refill the house with new things almost instantly. And forced clean out actually re-traumatize these individuals and make the hoarding symptoms even worse. I'm not saying that a large scale clean out and very, very quick clean out is not an option. But what I'm saying is the individual with hoarding issue needs to say, okay, I'm ready. I want this kind of help, as opposed to being forced. All right. So before we take questions, and I will. Oh no. Okay, let's come back. So before I take questions, so these are the list of a list of resources that you can check online that includes Google local hoarding task force and Clutterers Anonymous and buried in treasure groups that may be in your own area. And I'm also doing compassion-focused therapy groups in San Francisco. If you are interested, please feel free to email me and check Mental Health Association in San Francisco. They may not know a lot about your own state, but they may be able to connect you with your local resources. All right, so I think that's all I have for today. So I will
Mm-hmm.
be happy to take questions now.
Perfect. Okay, so we have a good amount of questions, and our first question is, I have a client that is in denial about her hoarding tendencies. How would you navigate denial?
Mm, yeah, so this is a very common challenge, and this is one of the biggest hurdles to work and to help these individuals. So I don't have a definite right answer. However, I can share how I would approach this. So I would start from looking at the well-being, the overall well-being of this individual. So that means I wouldn't be focusing on the hoarding behaviors. I would be looking at their overall well-being. So I would be curious and I would be asking them, "Oh, how are you today?" And be curious about how did you sleep last night, for example. Things like very basic. How did you eat? How did you sleep? Were you able to do the exercise that is good for you? And so, for example, if the answer was no, I didn't sleep well last night, and be curious about why. And so that kind of because a lot of times the sleeping problem is related to hoarding. However, we don't want to let the people think that we only care about their quote unquote messiness, and we want to care about them as a person. So how did you eat? And oh, so I didn't eat well because I can't use my kitchen. Oh, how can is there anything that I can help you to make your kitchen usable for you? So it's I guess the overall headline here is to look at the well-being of the individual as opposed to the hoarding behavior, and that as a
Mm-hmm.
way to help them to increase their awareness about how well they are living.
Okay. The next question is there an overlap in hoarding disorder and borderline personality disorder?
Hmm. That is a good question. So borderline personality disorder is not one of the most common co-occurring conditions with hoarding disorder. The most common co-occurring condition is depression, and followed by PTSD or other anxiety-related disorders. And however, it's not, I have seen clinically that people with hoarding disorder also showed borderline personality disorder trait.
Okay, so the next question that we have, and thank you for these great answers. Um, Give me one second. Any tips care managers who enter clients' homes and see this regularly for what to say about it when you see their home for the first time?
Hmm. Yeah, I think that my answer to this would be kind of similar to my answer to the first question. Be curious about the person's well-being as opposed to the things in their homes. And so a lot of times when we look at hoarding disorder and think about how to address this issue, we are looking at the things. And when we look at but that's missing the real target. And so the things are just manifestation of what's going on inside the individual. So remember, it's the effect of trauma, for example, it's the emotional attachment, it's the fear of making the wrong decisions, it's the lack of self-confidence and self-acceptance that makes people have this challenge, and that makes that kind of manifest to the state of their home. So it's really really easy to miss the focus and really focus on the things in the home but not the person. And so again, yeah, just focus on the well-being of the person and help the person to become aware of, oh, maybe I'm quote unquote suffering in this way, and try to help them to become more mindful about how they are living.
Thank you. I have another question. I am taking this webinar to understand why I am a hoarder. I started 30 years ago and have a hard time throwing out things. Just for the reasons you explained, emotional attachment, things I think I'll only later on in life, etc. How do I start to improve my own situation?
Hmm. So if you would be open to groups, I would encourage you to participate in groups. The reason why I think that would be a very good starting point is in a group setting as opposed to an individual therapy, you get to meet other individuals who share similar challenges. And that I often find that that's tremendously helpful for people to start to grow compassion for themselves. And I would suggest that as the first step, and to start to understand you're not alone in this challenge, and this is not your fault that you have this issue, and to have compassion and how you can then receive other types of professional help.
Thank you. We have, I know we have a couple of minutes left, and you need to be off at 2, right?
Yes.
So we probably have time for maybe only two more questions. I do apologize. I know we do have a lot of questions. Um, let me see.
Yeah, so I also would like to say, yeah, I do have to end this on time. However, please feel free to email me your questions. You have my email address here on this page of the slide, and I will try my best to reply to your email as soon as I can.
Okay. Another question. At what point should adult protective services be involved?
Mm, yeah, I am not very familiar with how the adult protective services people. I'm not familiar with their criteria. However, in the task force that I'm part of in San Francisco, we do have adult protective service people attending, and based on my observation and my what I hear, it seems that they would be involved when they realize there is a threat to the individual's safety, and if the older adults are not able, if they are not able to take care of themselves, and they are self-neglected due to whatever reasons, and then that would be when they would make the call to step in, I think.
Thank you. We have a question actually. What about animal hoarding? Are there
Mm,
any studies that people who collect cats, dogs, or other living things? What is up with, if people have over 100 cats and dogs in their home? Any difference in the people who hoarding behaviors and who hoard inanimate things. So is there a difference between people who hoard animals as opposed to objects?
Yeah. So this is a very good question, and the there are a few studies looking at people who hoard animals. However, I have come across two or three papers that look at this phenomena. So I don't feel like I have a lot of knowledge base to share this. I can just share from my clinical observation, is that my in my observation, it seems animal hoarding is relatively rare than people who hoard other not animals kind of things. And yeah, I actually, yeah, I have to be very honest. There isn't any study or I don't have enough knowledge base to answer in terms of the differences of the two types of hoarding.
Thank you. Do we have time for one more question, or could I ask you
Yeah.
another question?
Yes, I can take one more.
Okay. When a person is living in a nursing home and you have to help them clean things out weekly due to environmental and safety issues, how do you navigate this, specifically hoarding food?
Hmm. Is this question specifically about hoarding food?
Yeah, it sounds like the person works in a nursing home and they have to do rounds, and how do you help someone who hoards food in their room?
I see. Um, I would again, coming from a trying to understand and trying to improve their well-being kind of stance, and to share with them that your concern in terms of how having a lot of food in their home may affect their health. And so again making it very clear to the individual that you are not here to judge um, this is right or wrong, but you are here to want to help them to improve and to prevent anything that's harmful for their health to occur to them. And so then discuss the reasons um, why they need these things, and are there other ways that can achieve these goals. Yeah, but I would say that this will be challenging, but this is at least a starting point for the
Okay.
conversation.
Well, like you said, if unfortunately we have a good amount of questions that we're unable to get to, and we do apologize, but um, uh, they could email you, right? Is that correct? Do you mind them emailing you their questions and just giving a good amount of time to respond back? Is that okay?
Yes, yes.
Okay, so the email is on the resource page, and I'm going to send it to everyone just in case you don't see it. I can't thank you enough. I learned so much new information today, and just based on the questions and all the thank yous and amazing presentation, you really taught us some new information today. And I really thank you for volunteering your time and your expertise and explaining things in a way that we all understood. I hope everyone has a wonderful holiday. And as always, we welcome everyone back to our next Care Connection webinar, and I hope everyone has a wonderful rest of the day. Thank you so much.
Thank you very much, Heather, and thank you everyone.
All right. Have a good day. Bye bye.
Bye bye.